Hello everybody, my name is Ahmed Zaidan and today we're going to be explaining oogenesis and folliculogenesis, topics important for the BAU entrance exam. Oogenesis is a complex process of female egg formation. Folliculogenesis is the development of surrounding ovarian follicles. Both are distinct from spermatogenesis, which we will explain in another video, starting prenatally and involving crucial meiotic arrests and hormone regulation. Why this matters? Understanding these processes are vital for diagnosing and treating female infertility, comprehending menstrual cycle disorders, and developing reproductive health interventions in medicine, pharmacy, and dentistry. A frequent misconception is that oogenesis is a continuous process like spermatogenesis, when in fact it starts in fetal life and ends at menopause. It involves two distinct periods of meiotic arrests. Let me start by explaining oogenesis, which is the creation of a female gamete, or the egg, and folliculogenesis is the creation or development of ovarian follicles that support and nurture these eggs. You will learn how these processes differ significantly from male sperm production, particularly concerning their timing and the unique phases in pauses in meiosis. Key definition and concepts. Oogonium, which is basically a germ cell, is a diploid 2N, which means it has 46 chromosome stem cells in the fetal ovary that undergoes mitosis to produce primary oocytes. It's important to remember that before meiosis, there must be mitosis, which would lead to production of primary oocyte. A primary oocyte is a diploid 2N cell that enters meiosis 1 during fetal development, but arrests in prophase 1, which is a phase of meiosis 1, until puberty. This arrest is also important. That allows for genetic recombination. Secondary oocyte is a haploid N, which means 23 chromosomes, cell formed after the completion of meiosis 1, which is an unequal division or reductional division, which then arrests in metaphase 2 until fertilization. Keep in mind that meiosis 2 is similar to mitosis. There is no reduction of genetic information. There is just a replication. Polar body is small, non-functional cell produced during oogenesis due to unequal cytoplasmic division, designed to discard excess chromosomes. Fertilization is the fusion of a sperm and an egg, which triggers the completion of meiosis 2 in the secondary oocyte. A zygote, or a mature oocyte, is the fertilized egg, or the end product after completing meiosis 2. A primordial follicle is the most immature follicle in the ovary. It consists of a primary oocyte surrounded by a single layer of pre-granulosa cells formed during fetal development. Now, primordial follicle is the shell, as we said, that will cover this primary oocyte, but later on, the primordial follicle will undergo a faster development than the oocyte. And you'll see what I mean in just a second. A primary follicle is a follicle that develops from the primordial follicle, characterized by cuboidal granulosa cells surrounding the primary oocyte. The zona pellucida also forms. Now, the zona pellucida is a thick glycoprotein layer surrounding the oocyte. It's crucial for sperm binding and preventing polyspermy after fertilization. A secondary follicle is characterized by multiple layers of granulosa cells and the appearance of theca cells, a theca interna and theca externa surrounding the oocyte. I will explain what I mean with this image. As you can see, this is a later stage of a follicle. Disregard the antrum, but I will explain it in just a second. You will see that there are granulosa cells, which are cuboidal cells that are surrounding the whole oocyte. There is a theca interna and theca externa. Now, the theca externa is going to be responsible for hormone production, and we will explain that in just a second. But as you can see, the zona pellucida is basically a glycoprotein that will surround this oocyte, and it's very important in sperm binding. A corona radiata, if not mentioned in the notes, but I will explain it, it's basically a type of granulosa cell that will change its form to become very flattened, that will surround our oocyte. Because during ovulation, at the end stage, the complete corona radiata means a crown, it's surrounding the whole oocyte, will also join or come with the oocyte. Now, a tertiary or an antral follicle is a mature follicle with fluid-filled cavity called the antrum. Though not explicitly named in detail, its progression from secondary. Gravian follicle, the fully mature tertiary antral follicle ready for ovulation. Now, a Gravian follicle is an important stage because, as you can see, this antrum will continue to keep on filling and like basically push these granulosa cells on the edge. And this corona radiata will bind more and more to our oocyte until our luteinizing hormone, which is a hormone secreted by our pituitary, rises high enough, and this oocyte will be expelled. Atresia. It's the degeneration and resorption of ovarian follicles, a process by which most oocytes are lost from fetal development to puberty. Hypothalamus is the brain region that produces gonadotropin-releasing hormone. Hypothalamus is basically a part of our brain that is above the pituitary, and it's really important because it controls most of our brain regulating mechanisms, and it's also responsible for releasing the gonadotropin releasing hormone. It's a hormone from the hypothalamus that stimulates the anterior pituitary. Anterior pituitary is a gland that releases luteinizing hormone and follicle stimulating hormone in response to gonadotropin releasing hormone. Luteinizing hormone is a pituitary hormone that stimulates theca cells and triggers ovulation by an LH surge, which means when the luteinizing hormone is very high. Follicle stimulating hormone, FSH, is a pituitary hormone that stimulates granulosa cells and promotes follicular growth. Theca cells are cells in the ovarian follicle that have LH receptors and contribute to estrogen production. Granulosa cells are cells surrounding the oocyte in the follicle that have FSH receptors and produce estrogen. Estrogen, or estradiol, is a female sex hormone produced by the ovarian follicle, crucial for follicular development and feedback regulation on the GnRH, LH, and FSH. It does a negative feedback. Ovulation, the release of the secondary oocyte from the mature ovarian follicle, and it happens at day 14. A step-by-step explanation. As we said, oogenesis is the formation of the egg. Oogonium is the oogonium formation, or fetal life. During fetal life is the process that begins in the fetal ovary with oogonia or diploid stem cells. These cells undergo mitosis to increase their number. Primary oocyte and meiotic arrest, in which oogonia differentiate into primary oocytes, which are diploid. These primary oocytes then begin meiosis 1 but arrest at prophase 1. This arrest lasts from fetal development through birth, childhood, and until puberty. A common misconception, unlike males where spermatogenesis begins at puberty, female egg production initiates prenatally. Completion of meiosis 1 at puberty. At puberty, under hormonal stimulation, mainly FSH and LH, a few primary oocytes each month complete meiosis 1. This division is unequal, resulting in one large secondary oocyte and one small first polar body, haploid. Both are haploid. The large secondary oocyte will contain most of the cytoplasm and organelles. That's why this polar body will degenerate. Secondary oocyte and meiotic arrest. Number 2. This happens at puberty till fertilization. The secondary oocyte then immediately begins meiosis to arrest, but arrests again, this time at metaphase 2. This arrest persists until fertilization occurs. Excuse me. Completion of meiosis 2. Upon fertilization, if the secondary oocyte is fertilized by sperm, it rapidly completes meiosis 2. This again is an unequal division yielding one large mature oocyte and one small second polar body. Folliculogenesis is the development of the follicle. Primordial follicle in fetal life. During fetal development, each primary oocyte is surrounded by a single layer of flattened pregranulosa cells forming a primordial follicle, as we explained. The primary follicle from fetal life till puberty, the pregranulosa cells become cuboidal, forming a primary follicle. The zona pellucida, a protective layer, also forms around the oocyte. This stage also occurs from fetal life till puberty. Secondary follicle. A secondary follicle, which spans from fetal life till puberty, in which the oocyte grows, granulosa cells multiply to form multiple layers, and new theca cells appear, theca interna and externa. This development also occurs from fetal development to puberty. Atresia, which is death, degeneration, and death. Throughout fetal life, childhood, and puberty, a significant number of these developing follicles and their oocytes undergo atresia. A female is born with about 1 million oocytes, which reduces to about 300,000 by puberty. Hormonal influence at puberty. GnRH, LH, FSH. At puberty, the hypothalamus begins releasing gonadotropin-releasing hormone in a pulsatile manner. The gonadotropin-releasing hormone stimulates the anterior pituitary to release luteinizing and hormone and FSH. Follicular growth and estrogen production. FSH acts on granulosa cells because the granulosa cells have FSH receptors within a cohort of 10 to 30 secondary follicles each month, rescuing them from atresia and promoting their growth. LH acts on theca cells, which have LH receptors, stimulating them to produce androgens. These androgens are then converted to estrogen specifically and by the granulosa cells with the help of FSH. Negative feedback of estrogen. Initially, as estrogen levels rise due to follicular growth, they exert a negative feedback on the hypothalamus and anterior pituitary, suppressing GnRH, LH, and FSH release. This causes less mature follicles with fewer receptors to undergo atresia, ensuring only the strongest follicle continues to mature. A positive feedback and LH surge, the most mature follicle continues to grow and produces a very high level of estrogen. This high estrogen level then switches to positive feedback, causing a sudden surge in LH and FSH with a particularly strong LH surge. This mostly happens at day 14 of the menstrual cycle. The LH surge is the key trigger for ovulation. It causes the mature follicle to rupture, releasing the secondary oocyte, which is also still arrested in metaphase 2 and surrounded by some granulosa cells, usually around day 14 of the menstrual cycle. The oocyte then travels into the uterine tube, awaiting for fertilization. Key takeaways and professional relevance. Oogenesis and folliculogenesis are fundamental to female reproduction. Their unique timing and intricate hormonal regulation underscore the complexity of the female reproductive system and its delicate balance. Medicine. This knowledge is important for understanding the menstrual cycle, diagnosing cause of infertility, anovulation, polycystic ovary syndrome, managing menopausal symptoms, and developing assisted reproductive technologies, ART, like IVF. Pharmacy. Pharmacists utilize this understanding to counsel patients on hormonal contraceptives, fertility medications, hormone replacement therapy, and drugs that may interfere with reproductive processes. They also advise on proper use and potential side effects of such medication. While not directly involved in reproductive care, understanding the hormonal influence on systemic health, including reproductive hormone, can provide insights into patients' overall health status, drug interaction, and specific conditions like pregnancy, gingivitis. This is important for dentistry. Key areas to focus on for the exam include the difference between oogenesis and spermatogenesis, the stage of follicular development, the roles of GnRH,